Greetings, students. My name is Dr. Tamika Thompson, and today we will be discussing systemic and localized chemotherapeutic agents in treating periodontal disease. In discussing systemic chemotherapeutic agents, there are several classes of drugs that fall under this. The antimicrobials or antibiotics, they actually decrease the bacterial load. Anti-inflammatories, such as NSAIDs, non-steroidal anti-inflammatory drugs. Ibuprofen or Motrin would fall under this. Protease inhibitors, such as Periostat or low-dose doxycycline, basically inhibit certain enzymes like matrix metalloproteinases that actually break collagen down. And just remember, the last two categories actually both decrease inflammation, which is a major component of periodontal disease. When we talk about periodontal disease and the treatment of periodontal disease, there are various terms that can be utilized. The term anti-infective therapy is a term that is inclusive. It actually includes both mechanical debridement, which we know is very necessary in order to treat periodontal disease and have the proper response, as well as chemotherapeutic agents. The questions you want to ask yourself, though, is it necessary to use both? Can you do one versus the other? And then if you can, why or why not? In utilizing the systemic chemotherapeutic, they are used as an adjunct only, and they are indicated primarily in cases where the inflammation is severe or persistent. Mechanical debridement is still the primary mode of treatment, and as long as you adequately remove the biofilm or the calculus that houses the plaque, then the body will have a favorable response in terms of probing reduction and decrease in inflammation. When considering the impact of antimicrobials against the biofilm, one needs to know that the biofilm is actually resistant to the attack of the antimicrobials and the antiseptics. Because of the fact that the bacteria within the biofilm utilize each other's properties and their strengths, they have now evolved to a point where they are resistant to the antibiotics or antimicrobials. As far as the dosage of the antibiotics, the planktonic phase, which is the free-floating bacteria, are the only ones that respond to that antibiotic. But the biofilm in itself, because of how complex it is, and again because of the fact that it's synergistic with the other bacteria that are present, meaning they actually use their strengths to be resistant again to the antibiotic, then the biofilm again is unaffected, and therefore systemic chemotherapeutics or local chemotherapeutics alone will have no impact on the biofilm, or very little impact. In prescribing antibiotics, we want to prescribe antibiotics only to certain patients. Those patients that respond well, which are most patients, to conventional therapy have no indication for antibiotics. The list where we would indicate antibiotics would be patients that are non-responsive to conventional therapy, those that have acute periodontal infections with systemic manifestations, those patients that are medically compromised, that are on a prophylaxis or a maintenance and they really require surgery or more comprehensive periodontal therapy. And finally, we use them as an adjunct to surgical and non-surgical periodontal therapy in a case-by-case basis as indicated. When we think about prescribing antibiotics, we have to understand, how do the antibiotics actually enter into the gingival sulcus? Well, the antibiotics enter into the gingival sulcus through the bloodstream. This is important because we want them to be able to reach the necessary site. And by either ingesting the medication or having intravenous, intramuscular injection, that's how we end up getting into the bloodstream, into the different areas of the body. The benefit in doing this is that these antibiotics may also have an impact on the recolonization by suppressing pathogens that are located on the tongue, cheek, and other surfaces of the oral cavity. Now, why would we just not add in antibiotics for every patient? Well, there are reasons why we don't want to overtreat a patient. One, the inability of systemic drugs to achieve high GCF concentrations. So if they cannot maintain high concentrations in the gingival clavicular fluid because it's constantly turned over, then that's one of the disadvantages of systemic antimicrobial. You're still having a systemic effect, but where you want it is being turned over too rapidly. Therefore, that would be a disadvantage. Also, you always increase the risk of adverse reactions anytime you incorporate a medication, not just an antibiotic. There's also an increased selection of antibiotic resistant microorganisms. As bacteria are continuously exposed to that same antibiotic, sometimes they evolve and become resistant or have resistant strains of bacteria to that antibiotic. That's something we want to be concerned about, because when we really need the antibiotic for a higher risk infection, sometimes that antibiotic won't work, and then we are limited in what we can use. And finally, uncertain patient compliance. Just because you prescribe the antibiotic doesn't mean the patient is going to utilize it all. And if they don't utilize it all, that's one of the ways that microorganisms or bacteria become resistant to the antibiotic, because you have not given that full therapeutic dose. Another question we want to answer is, should we culture the bacteria or not? Is this beneficial? Is this non-beneficial? What do you think? Usually, we don't culture the bacteria. There are several reasons why, but one key reason is the fact that when we culture the bacteria, we don't really know if we're getting the bacteria that are causing the disease or not. Therefore, we rely on empirical data, meaning research that has been done in the past, which has shown us certain antibiotics that work. In looking at the culture and sensitivity tests, there are also other reasons why we may decide not to culture. One, periodontal disease is predominantly a gram-negative anaerobic infection. Therefore, we know that we are targeting gram-negative anaerobes, and we have information about antibiotics to know if they are broad spectrum or limited spectrum, and actually what organisms they target. Again, as we have previously stated in the previous slide, disrupting of one of the bacteria or microorganisms may impact the others, and therefore you don't know which bacteria you're actually getting. Are you getting the ones that are causing the disease, or are you just getting bystanders? Because remember, they make up a complex biofilm. Next, the antimicrobials targeting this spectrum, again, are beneficial. We already know that they work. And so if we have antibiotics that work already, why would we send a patient to have a test that we know is expensive, only to end up coming up with the same information that we already had before the test? Now, nothing is 100%. So there may be times where you would culture, where you've tried everything else and nothing is still, the patient is still not responding. But for the most part, the culture and sensitivity tests are not necessary, because most patients respond adequately with the antibiotic and the debridement combination. The following chart, taken from the Rose and Milley textbook, shows adverse reactions that are associated with the different antibiotics or drugs. For instance, the penicillin, one of the key features you'll see as an adverse reaction is allergies. For doxycycline, which is one of the tetracyclin family, dental discoloration. So therefore, we know not to give this drug to pregnant women or children that are in the process of having their teeth formed. Metronidazole shows that if they drink alcohol while they're on this medication, they will have a reaction that's called antabuse, where they have severe nausea and vomiting, and that can also be fatal. And then with the clindamycin as well as the erythromycin, diarrhea
is highly likely. The other key feature as far as an adverse reaction where metronidazole is involved is that it has the potential to be teratogenic, which means it has the potential to cause birth defects. Whenever you are giving a patient an antibiotic or a drug, you have to be mindful of the different interactions that may occur. As far as the metronidazole and erythromycin, both of those can increase anticoagulation effects of warfarin. So you always want to make sure you do a thorough medical history and understand which drugs the patient is taking. The tetracycline actually increases the serum levels of digoxin, which is actually a heart medication. Drugs that affect the GI tract, such as antacids, can affect absorption of the tetracycline as well as the clindamycin. So you have to be mindful of what you eat as well as what you drink as well as what you're taking. So for instance, you would not take milk if you were trying to utilize tetracycline and allow it to be effective. So no matter what you do, you always want to check the drug interactions. As far as treating periodontitis, this can be done with either a single or a combination antibiotic. For instance, necrotizing ulcerative gingivitis can be treated with metronidazole alone. Localized aggressive periodontitis can be treated with metronidazole and amoxicillin, which is a combination, or it could be treated with tetracycline. However, there have been some bacteria that have shown to be resistant in the past, and therefore tetracycline is no longer commonly used. Doxycycline at 100 milligrams once a day for 7 to 14 days has also been shown to be effective. There have also been cases where clinicians are starting to use antibiotics for severe chronic periodontitis. Metronidazole and amoxicillin again, and then metronidazole and ciprofloxacin. The next key question is, if you're going to use an antibiotic, what is the best time that an antibiotic should be given? Well, definitely during periodontal therapy and during the healing. Therefore, most of the time we should plan to complete scaling and root planing if we can in one day appointment, or it could be 1 to 2 days, or you at least want to finish during the time that you give the antibiotic. So if the antibiotic lasts for 7 days, then it would be beneficial for you to get that scaling and root planing done within those 7 days. So remember that the therapy should be completed, or the antibiotics can actually be extended for a longer duration. Just to provide some more specific information about the different antibiotics so you'll know exactly how they work, the penicillin is a beta-lactam bactericidal compound. Remember, bactericidal means it actually kills the bacteria. It kills the bacteria by inhibiting the bacteria cell wall synthesis. Many organisms, however, have developed a resistance to the penicillin through the production of beta-lactamases. So those enzymes actually attack the penicillin, which is a beta-lactam. Because of that, you can actually add another antibiotic to the penicillin in order to make it effective still. However, again, we talked about one of the key adverse reactions is allergy or hypersensitivity. As mentioned in the previous slide, penicillin can be combined with another antibiotic in order to inhibit the bacterial resistance that occurs with penicillin alone. That's where Augmentin would come in. Augmentin is a proprietary combination of the penicillin derivative amoxicillin and clavulanic acid. The clavulanic acid is the portion that actually inhibits the beta-lactamase that is excreted by the bacteria, which actually prevents the bacterial resistance to the amoxicillin. Tetracycline is actually bacteriostatic. It is a broad spectrum agent that actually inhibits protein synthesis. Most common tetracycline is used in periodontics. Doxycycline is the first, and then minocycline is the second, or minocycline rather. Both are completely absorbed through the intestine with less effects on the GI flora. Therefore, they don't have the same contraindications or specifications that tetracycline has as far as watching what you eat and or drink. Tetracycline has the ability to inhibit tissue collagenases and other matrix metalloproteases, which actually create the periodontal destruction. So by inhibiting these enzymes, you actually prevent the collagen from being broken down. Hence, you prevent bone loss. Due to the extensive use, bacterial resistance has actually been reported with the tetracycline, as previously indicated. Tetracycline actually depresses prothrombin activity. So patients that are on anticoagulation therapy, they may actually need to lower the dose of their anticoagulation medication. Also, the effectiveness of bactericidal antibiotics is decreased if you use those simultaneously with the tetracyclines. Remember, you have a bacteriostatic as well as a bactericidal. Most of the time, these should not be used together because one stops the bacteria and one actually kills the bacteria.
The tetracycline antibiotics should not be given with milk and dairy products, should not be given with the iron or any cations plus 2 containing vitamins and minerals or antacids. The reason why is because the absorption of the tetracycline is impaired by those minerals such as calcium, iron, magnesium, and aluminum. Other factors associated with tetracycline are photosensitivity. If you have women of childbearing age, you have to let them know that their birth control pills will be inhibited while they're taking the tetracycline, so they may want to use some other form of contraceptive. And you also want to avoid the use in children, pregnant, and nursing moms because the tetracycline becomes incorporated into the teeth and it stains.
With doxycycline, as mentioned previously, the absorption from the GI tract is not impaired by calcium, metal ions, or antacids. It actually may be taken with food or dairy products also. Decreased absorption has only been seen in about 20%. The label, though, you have to realize may read otherwise. So if you wanted to just be completely careful, you would just tell them to be careful with food or dairy products as well. And as far as the doxycycline, you're actually getting better patient compliance because of everyday or twice a day dosing versus 3 times or 4 times a day. Anytime you decrease the amount of times that a patient has to take the pill, what studies have shown is that compliance has increased. There is also a sub-antimicrobial dose doxycycline. We call that periostat. That's actually 20 milligrams twice a day, and that can be taken for 6 to 9 months. Some studies even show that the doxycycline can be taken up to a year. You have to remember, because it's in a sub-antimicrobial dose, it's not acting as an antibiotic. It actually downregulates the activity of matrix metalloproteinases. It can be also used as an adjunctive therapy, which can result in a significant gain in attachment level and probing depth reduction. The non-steroidal anti-inflammatory drugs such as ibuprofen or Motrin, they actually inhibit pro-inflammatory agents. 2 of the key pro-inflammatory agents that they hinder are the prostaglandin and the arachidonic acid metabolites, which are key mediators in bone resorption. One of the negative impacts of NSAIDs is that it has gastrointestinal effects, and thus this drug cannot be used long term even though it has shown to be beneficial. But due to the adverse effects or reactions, it has to be limited. Now that we have discussed all the antibiotics and their mechanism of action and their relationship to
and the treatment of periodontitis, we have to look at the big picture. So what is the big picture? What is the take-home message? The take-home message is that mechanical therapy alone is sufficient for most patients with chronic periodontitis. Therefore, we do not need to incorporate the systemic antibiotics and create situations where we can develop bacterial resistance and so forth. You would only use them again in situations where you see that therapy alone is not being effective. Also, it can be used as an adjunctive chemotherapeutic therapy, and that again is when it's indicated. So that is on a case-by-case basis. For the sake of comparison, as we start to talk about topical delivery versus systemic delivery, I've included information for systemic delivery on this slide. However, when we focus on the topical delivery, we're looking at things such as the mouth rinses, toothpaste, gels, irrigation, so forth. This would consist of intraoral placement of chemicals as well as local delivery using controlled release. When we start looking at mouth rinses and we want to look at the characteristics of an ideal mouth rinse, we would be looking for efficacy, where the active ingredient should actually inhibit or kill the periodontal pathogens. We want a mouth rinse that's stable, so it needs to be stable at room temperature and it needs to have a reasonable shelf life. Third, substantivity. That just means the ability for that product or that rinse to stay around. So we want something that is retained in the mouth and can be released over time. And finally, we want to look for a product that is safe. We don't want any harmful effects to the tissue. With any product, you're going to have active ingredients. Active ingredients are the components that actually produce some benefit for the patient. When you look at the table below, you can see the ingredients on the left-hand side of the table and then actions on the right. So for instance, if you take the pyrophosphates, it actually reduces supragingival calculus. So you always want to know what the active ingredients are, especially so that you can counter whatever adverse effect that your patient may be having. So for instance, if they're having a lot of calculus buildup, then you may want to include a toothpaste that has the pyrophosphate in it. In looking at topical delivery mechanisms for chemical agents, there are the specific mechanisms in column 2 that can either be via a mouth rinse, a dentrifice, or a toothpaste. Could occur via subgingival irrigation, a controlled release delivery device, and the final one is for systemic. And then to the right hand again are possible patient benefits, which usually occur again as a result of the active ingredient. This slide was included just so you could have a comparison of drug delivery systems for management of periodontitis. So when you look at mouth rinsing versus subgingival irrigation versus systemic delivery, we see that at the very bottom, controlled release delivery actually has the best outcomes in terms of providing adequate drug concentration, the fact that it actually will reach the site of the disease activity, which is important, and that it will be able to stay in place because of the fact that it has a controlled release, whereas everything else for the most part will either wash away or it will not be an adequate drug concentration, or it won't be in the site long enough to be effective. And underneath that chart on table 25-3, basically there's just the overview of some of the chemical agents that are used in controlling the biofilm. We'll focus a little bit more on phenolic compounds or essential oils as we talk about products such as Listerine, and then as well as the bisbiguanide antiseptics, the chlorhexidine, which again is known right now in terms of mouth rinses as the gold standard. Now, with any good product, a lot of times you're going to have possible side effects. So we're going to talk about the possible side effect of mouth rinses. We're going to focus on the mouth rinses that contain either the essential oil rinses or the chlorhexidine. When we look at the essential oil rinses, side effects could be burning sensation in the mouth, bitter taste, and the drying out of the mucous membranes because of the alcohol content. So in this particular case, you may want to be careful about prescribing this medication or this rinse to someone that has xerostomia. If they're already dry, you don't want to introduce another product that's going to dry them out even further. The chlorhexidine, on the other hand, could have the potential side effect of an allergic reaction, extrinsic staining of the teeth, which is very common, discoloration of the tongue, alterations of taste, increase in calculus formation, which also is very common, and transient anesthesia. Remember also that the chlorhexidine, outside of side effects, actually requires a prescription, whereas the essential oils are something or products that are purchased over the counter and do not require a prescription. When we look at utilizing localized chemotherapy as an adjunct to periodontal therapy, then the indications would be if we had isolated, persistent, deep probing depths. So again, be mindful of isolated. You can't have generalized, persistent, deep probing depths and then use a localized chemotherapeutic. You would just use a systemic chemotherapeutic. Also, when plaque control is inadequate, and it might be due to dexterity or it could be due to the mental capacity, you may incorporate this again in cases where the persistent deep probing depths are isolated. That means roughly 1 to 2 sites in a quadrant. Chlorhexidine in the U.S. comes in 0.12%. It is the most effective antimicrobial for reduction of biofilm as well as gingivitis. In fact, chlorhexidine is known as the gold standard. The mechanism of action of chlorhexidine is to disrupt the integrity of the cell walls of the bacteria. Although the chlorhexidine comes in 0.12% in the US with 11.6% alcohol, outside of the US it comes in a higher concentration in 0.2%. However, there is no significant difference in the antimicrobial or clinical effects. But again, as we had stated earlier, it reduces the plaque by about 50 to 55% and reduces the gingivitis by 45%. In utilizing the chlorhexidine, you will use 15 milliliter rinse for 30 seconds twice a day, and there is no brushing or rinsing for 30 minutes. You also have to be mindful that when using products that contain sodium lauryl sulfate as well as fluoride, you may decrease the effectiveness of the chlorhexidine. It is effective as a pre-rinse to decrease the bacterial load if you are doing scaling and root planing, and it also enhances wound healing. Essential oil mouth rinses may include thymol, menthol, eucalyptol, or methyl salicylate. They are effective against gingivitis, and the mechanism of action is disruption of the integrity of cell walls and inhibition of certain bacterial enzymes. In incorporating supra and subgingival irrigation, the supragingival irrigation has been shown to decrease inflammation by removing the plaque. The subgingival irrigation has been shown to temporarily improve inflammation and biofilm by reducing both of those components. Calculus, however, has been shown to impede the subgingival irrigation. Therefore, if you do scaling and root planing, in addition to the subgingival irrigation, the results have shown improvement. And subgingival irrigation actually works very well in hard to reach areas. But overall, we need more well-designed studies to truly say that sub-irrigation is necessary. Other localized factors that have been utilized are tetracyclin fibers, When patients had tetracyclin fibers placed subgingival, they were instructed not to brush or floss the area for 2 weeks. They would rinse twice daily with chlorhexidine. And the tetracyclin fibers have been shown to release bactericidal concentrations for up to 10 days. However, they're rarely used today. Another component that can be used in localized areas is the chlorhexidine chip. It is a self-retentive chip that actually contains 2.5 milligrams of chlorhexidine. It is difficult to place in pockets that are less than 5 millimeters because the chip itself in height and width is 4 by 5 millimeters. The good thing is it does not have to be removed, it dissolved, and it has only been tested in conjunction with scaling and root planing. As far as the chlorhexidine released, that at 2 hours after placement, it is released at 2007 micrograms per milliliter and then progressively decreases over 9 days. The next agent would be the Doxycyclin Gel, or Atridox, which is a liquid biodegradable polymer, comes in 2 syringes, and it's injected into the pocket via a blunt cannula, but it can also come pre-mixed, and it hardens immediately after exposure to the gingival crevicular fluid. The Doxycyclin Gel is released at approximately 250 micrograms per milliliter at the end of 7 days, and there is no brushing, flossing, or eating in the treated area for 7 days. You could utilize a perio dressing or adhesive. Those might be necessary in order to maintain the gel in the gingival sulcus. And this has been approved as a monotherapy, but it will not remove calculus on the root surface. Remember, the only thing that removes calculus is debridement via instrumentation. The next localized chemotherapeutic agent would be the Minocycline microspheres. This is the Arestin. You will actually get a chance to hopefully utilize this. The hygienists apply it all the time here. The Arestin is an antibiotic that's microencapsulated in a bioabsorbable polymer. It is utilized as an adjunctive treatment, so not as a monotherapy. You don't need a removal appointment, but you do have to stress to the patient that they have to avoid brushing for at least 12 hours, and there's no interproximal cleaning, especially with floss, for 10 days. One of the positive characteristics of the Arestin is that it maintains its therapeutic drug concentration for about 2 weeks. This table is from the Rosen-Millie text, and it's looking at different delivery device techniques and then comparing it, scaling and root planing alone as far as the probing depth change with scaling and root planing plus the device. When you look at the scaling and root planing alone, which is the 4th column, and the scaling and root planing plus the device, you can see that there is a difference between the scaling and root planing alone and when a device is incorporated. However, you always want to look to see if something is statistically significant or clinically significant. So let's look at the 0.67 and then the 1.02. The thing is, you have to look at, or actually, let's drop down and look at the 0.64 and the 0.95. So I am 1, 2, 3, I am 4 rows down. And if you look at the 0.64 and the 0.95, those both are relatively going to be 1 millimeter. So clinically, you're not going to be able to see a difference between those. What you're actually looking at is to see if the inflammation has been decreased and if you don't have any bleeding on probing. The key take-home points from the last chart when you're looking at localized antimicrobial therapy, you want to be mindful that the periodontal health in the periodontal pockets is improved. When compared to scaling and root planing, the results are not superior. As a monotherapy is very questionable, but as an adjunct, it is beneficial.
Thank you for listening.